The University of Washington 2005 Science Forum features faculty research on the impact of human advances on our environment and within populations throughout the world. Toby Bradshaw looks at the long history of engineering plants for us to eat and explodes myths in the controversy over genetically engineered food. Marine biologist Virginia Armbruster looks at how human activities are affecting microscopic phytoplankton, which contribute 50% of the planet's oxygen. Chris Diorio introduces us to the little radio transmitter chips that will soon replace barcodes in tracking potentially everything in our world. Steve Gloyd talks about healthcare systems in poor countries and the obstacles they pose to delivering the affordable and effective AIDS treatments that are now available. And King Holmes looks at the prevention of sexually transmitted infections and tries to unravel why people don't take precautions. Join us as we determine the effects of human imprints. Exploring Our World is made possible by the University of Washington Alumni Association, the College of Arts and Sciences, the Office of Research, the College of Engineering, the School of Medicine, the College of Ocean and Fisheries Sciences, and the School of Public Health and Community Medicine. Additional funding for this program is provided by UW Medicine and the University Bookstore.
Welcome to the fourth lecture in the 2005 UW Science Forum series. I'm Dave Eaton. I'm the Associate Dean for Research in the School of Public Health and Community Medicine. We have a great lecture for you this evening, and I'm pleased to be your host tonight. I'd like to make a couple of comments about the School of Public Health. The School of Public Health at the University of Washington is the only accredited School of Public Health north of Berkeley and west of Minneapolis. So we have a very large geographic region that we cover. We have 5 departments in the School of Public Health: biostatistics, environmental and occupational health sciences, health services, pathobiology, and epidemiology. Tonight we're going to hear from Dr. Steve Gloyd, one of our truly exceptional faculty members in the Department of Health Services. And I'll introduce Steve in a moment. I'll say a couple of words about our Department of Health Services. Health Services is a broad area of medical and social sciences research that examines how people get access to health care, how much health care costs, what happens to patients as a result of this care. The main goal of health services research are to identify the most effective ways to organize, manage, finance, and deliver high-quality care to reduce medical errors and improve patient safety. Now, obviously from that description, it sounds as though much of the health services research going on in our university focuses on our own healthcare system and problems in healthcare delivery in the United States. Obviously, developing countries have hugely different problems in healthcare and healthcare delivery. Faculty in our International Health Program, which is a joint program that is based in the Departments of Health Services and Epidemiology in the School of Public Health, conduct research and provide important practical assistance to struggling healthcare systems in other parts of the world. The International Health Program is designed for health professionals, administrators, and policy analysts who intend to devote a significant part of their careers to improving health in developing countries. It's the goal of this program to contribute to the advancement of the world health through service, teaching, and research. Tonight you'll hear about the research of Dr. Steve Gloyd, who's a professor of health services in the School of Public Health and also an adjunct professor in the Department of Epidemiology and Public Health, an adjunct professor in the Evans School of Public Affairs, and an adjunct professor in family medicine in the School of Medicine. Dr. Gloyd was the founder and is the director of the International Health Program in the School of Public Health, and also currently serves as the academic director of the Population Leadership Program, which is a joint program between the School of Public Health and the Evans School of Public Affairs. Steve is a family physician who spent over 25 years working in Africa and Latin American communities studying healthcare with a focus on maternal and child health and sexually transmitted diseases, especially AIDS. He's currently involved in projects of which you will hear some about tonight with the Ministries of Health in Mozambique, as well as other parts of Africa. Tonight, Dr. Gloyd will discuss AIDS in Africa, obstacles and opportunities. Please help me welcome Dr. Steve Gloyd as he shares his extraordinary research and public health experiences in Africa.
First of all, I want to thank the organizers who set up this series, Karen and the groups of the Science Forum. It's a great series, and I'm quite honored to be asked to be one of the speakers. Secondly, I'm honored that all of you will take a beautiful, sunny afternoon in Seattle and spend it inside at Kane Hall for an hour and a half or so, and that says a lot. Finally, I'm honored to have my family here, my dad who comes and his wife who come to all of my lectures. He's one of my greatest fans, and unfortunately it means that I have to keep changing my lectures every time, because otherwise he'll tell me it's the same old stuff. This lecture is about science, and I tried to figure out how I could make the political economy of AIDS treatment science. So what I tried to do was, first of all, I did what any faculty member might do, is that I looked in the dictionary to figure out what science was and get some definitions, and the best one I found was knowing. And ultimately what we'll be talking about today is understanding different aspects of science that tell us about HIV. Public health science to understand the devastation of HIV in the world, and particularly in Africa. Medical science to understand the fact that treatment of AIDS works. It works tremendously well, and it also works to improve the preventive efforts that we've embarked on in the area of HIV prevention. Third, the dismal science, economics. Economics is extremely important in the whole area of understanding AIDS treatment in Africa, because much of the policies, the economic policies that are called the Washington Consensus, also called market fundamentalism by many people, have profoundly affected our abilities and the abilities of governments in Africa to be able to treat HIV. And then fourthly, political science, because political science is necessary to understand how to change policy. Because ultimately, if we're going to make any progress in the issues of HIV and AIDS, we're going to have to move to change policies. We'll start with the public health science, a little bit about epidemiology. AIDS, there are 40 million people who are infected with HIV. In Africa alone, about 24 million are infected, which means that daily we have about 10,000 infections, 7,000 deaths that have produced approximately 12 million orphans. And what that means is that in 10 countries, the countries that are the worst affected in Africa, about 25% of your teachers, your nurses, your doctors, your mothers, your fathers will be dead in 10 years. It also means that without treatment, about 70 million will die within the next 20 years. This gives you an idea of the distribution of HIV. And if you look at in sub-Saharan Africa, it's quite dark red. And that dark red indicates that the levels of prevalence are in the neighborhood of 15 to 36%. That means 15 to 36% of adults in these areas across the countries are infected with HIV. We work in places in central Mozambique where the numbers are about 30%. That means if we have a place like we have today, that you could almost count off 1 to every 3 and 1 to every 4, and that would be the approximate number of people who are HIV positive. It's now the leading cause of death in Africa. The causes of death have remained stable for a couple of centuries, and just in the last 10 years, AIDS has come to contribute an enormous amount to the deaths in Africa. And then when you look at life expectancy, this is really telling. It shows you that in at least 5 African countries, and more now, that starting from the level of the 1980s, 1985, to now, that the life expectancy was going up and up and up in many of these countries until AIDS hit, and then started to drop off. And dropped off precipitously, so that life expectancies in places like Botswana were as high as 62, 63, and have now gone down to levels just over 45, whereas places like Uganda, the life expectancy, the life expectancy went down under 40. Nelson Mandela said a couple of years ago that AIDS is a tragedy of unprecedented proportions. It's unfolding in Africa, that it's today is claiming more lives than the sum total of all wars, famines, and floods, and the ravages of such deadly diseases as malaria. AIDS is no longer a disease, it's a human rights issue. And I think most of us will agree with that. Then there's AIDS treatment. And we'll get a little bit into medical science now, which is that AIDS treatment works. It's as simple as that. AIDS treatment does not cure AIDS, but it will take somebody with a high viral load, and it can make that viral load undetectable in your blood. It reduces resistance, and the complex regimens make it very hard for people to take if you're taking the regimens that are common in this country. And these are regimens where you might take 2 pills in the morning, 1 pill midday, a very complex regimen that sometimes means you have to get up at night to take pills. But that treatment transformed the AIDS epidemic in the United States. This is a graph that gives you a little bit of an idea of how that's occurred. If you look at the graph with the AIDS cocktails, which became available, these are triple drugs, 3 drugs that you take several times during the day. But these AIDS cocktails, if you look at the blue line, that starting in 1995, there was a precipitous decline in the mortality, the likes of which you rarely see in any public health intervention. It was pretty phenomenal. And you can also see that the number of new cases declined as well, suggesting that there was something that was synergistic about treatment and prevention, or at least some aspect of AIDS or HIV acquisition. The issue about AIDS in treatment is that although it has transformed the epidemic in the United States and in rich countries, there's an enormous treatment gap in the rest of the world. And this slide shows you a little bit about that treatment gap. That is, in sub-Saharan Africa, you have a situation whereby you have AIDS deaths in the 2 million range. This is 2000, so you have 2 million AIDS deaths and less than 100,000 people using AIDS drugs. So a huge, huge gap. Whereas in the high-income countries, excluding Japan, you have precisely the opposite situation. You have more than 500,000 people who are using AIDS drugs and very few people who are dying of AIDS. That's obviously the pattern that we want. This gap also exists in Asia, but not nearly as much as in sub-Saharan Africa. And that's why today we're focusing on the situation in sub-Saharan Africa, because of that enormous gap, which you could look at as a human rights issue, and you could look at as an enormous potential to do something good. Why is there a treatment gap? Well, there's a treatment gap for a number of reasons. One is the cost of medicines. The cost of medicines for the American regimens that you buy here that are patented drugs are between $10,000 and $15,000 per person per year, which means about $40 per day. Adherence to medicines is a problem, because if you're taking HIV drugs, if you're taking these triple cocktails, you need to have adherence of about 95%. That means you need to take 19 of 20 drugs at the right time without missing them to be able to get a reasonable response. If you go down to 18 out of 20, your response will drop from about 10% failure, you'll go up to about 20% failure. That is from a 90 to 80% response. So it's very, very sensitive. So you have to take these drugs well. That HIV quickly will become resistant to any one of the medicines as you're using, particularly if you use them alone. So when we only had one drug, which was AZT, it was very, very common for people to take that drug for a short period of time. Resistance develops and it becomes largely ineffective. That there was a very major concern, particularly among our own public health community in this country and worldwide, for taking the pressure and taking the focus off of prevention. Everybody was worried that if we embarked on AIDS treatment, then AIDS prevention would take a back seat. And it's quite clear that you need to have prevention. In fact, prevention is much more important in many ways because you don't want to have new people getting HIV. And then finally, the infrastructure, which is that most of Africa, and in fact much of the developing world, but in particular Africa, is in a situation where they don't have adequate functioning health systems. The health clinics are in bad repair, the health workers are not paid enough, there are not enough of them, the supplies, the materials, and we'll talk about that in a second. And then finally, I think there's an underlying double standard that was probably a strong issue that created a tendency not to treat. Because frankly, even giving all these ideas for why there's a treatment gap, can we imagine that anybody would not treat HIV in this country just because we're worried about resistance or just because we're worried about the cost or whatever? There's a phenomenon called global apartheid, which was coined by a couple of people, Bill Mintner and Sally Booker, which is the idea nowadays in the last decade or so where one's opportunities, one's access to goods, and one's human rights are increasingly a function of your geographic location, your social class, and your race. And I think that that's increasingly becoming the case, and that's one of the reasons why AIDS treatment has not happened. Bill Clinton said in July of 2002 that we're slow to act because we think it's somebody else's problem. Because the wealthier, the more powerful people in the world see people with AIDS as being different, people who don't count as much as us. And that fighting AIDS means fighting the belief that some people don't count. And Bill Clinton, since that time until now, has been a very major advocate for AIDS treatment. Fortunately, social activism and generic competition has driven down the prices of AIDS drugs in Africa. The cost of drugs has been reduced thanks to efforts by the Clinton Foundation and by the generics from $40 to 40 cents a day. That is, the price of AIDS drugs has come down 100-fold. And what's also important from an economics point of view is that the companies that are making these drugs at 40 cents, and they're the same drugs, are making them in generic, very, very good factories, and they're making a profit on the drugs. So it does tell us something about the pharmaceutical industry, which is somebody else's lecture, but that I think that we need to discuss. The reason that the drugs are cheap is because, first of all, Brazil stood up to U.S. threats, trade sanctions, and produced their own drugs. They did this because many non-governmental organizations, advocacy groups in Brazil stood up and said, we need AIDS treatment, in very much the way that people did here in this country in the mid-90s. And what happened was that the Brazilian government was forced to apply some of the laws which made it perfectly legal for drug companies in Brazil to produce their own drugs with compulsory licensing, which is something that can be done as part of the WTO. But the United States didn't want it. The drug companies in the United States were afraid that it would, I think, break the golden egg that AIDS provides. And the U.S. trade representative under President Clinton threatened trade sanctions against Brazil. They said, forget it, we're still going to make the drugs. They did. This opened up things wide open so that then the drug companies in India started making drugs, and that's how we got the prices down to about 80 cents a day. And then with some changes that the Clinton Foundation has helped in terms of the economics of ensuring a guaranteed market, the amounts for the drugs have come down to 40 cents. The cost of clinical laboratory tests has also been reduced, so that it used to be that you would have a test that would determine if you needed to go into treatment or not, which is a CD4 test. Used to cost around $40, $50. In fact, it still does in this country, and now it's between $3 and $5, using the same technology, the same tests to get a CD4. So the prices have come way down. Other considerations in AIDS treatment and monitoring: in order to get an accurate AIDS diagnosis, you need an AIDS test. You don't need a fancy apparatus. And right now, there are tests to be able to determine your positivity simply by taking a drop of blood in a capillary tube, dropping that blood into what's called the lateral flow device, which basically will show a line if you're positive and no line if you're negative, with the control line that always comes. It costs about $1, and anybody can do it. And in fact, there's no reason, presumably, why you couldn't sell it in drugstores here, because it's so simple, but we don't sell it here. So we have an easy test for HIV. You don't need to do Western blots anymore like we used to do, because you can do 2 different types of these to get about a 99% accuracy in these tests. The other thing that's important is that most HIV does not need treatment as soon as a person is HIV. Treatment only occurs when the immune system gets to a point where it is so damaged that you need to have treatment to bring the immune system back up to the point where you won't get these opportunistic infections that occur with HIV. What that means is about 80% to 90% of all the people that you would test in a community who are HIV positive don't need the treatment right away. And that has huge implications economically. It means you don't have to just start treating people all the time right away. The third thing is the first-line treatment for about 98% of the patients is one pill in the morning and one pill in the evening. And I brought these pills just because I've always liked show and tell. It works in my kids' school, so I thought it should work here. And these are the pills, you know. This is a pill, Simple Mix It. It's an Indian pharmaceutical company. One of these in the morning, one of them in the evening. That's it. That's what treatment's all about. It's a cute pill. It's got different colors, you know, so that you can kind of tell that it's more than one drug. And they're very effective, and they're the same pills that many people take for the first-line therapy here. And then finally, that resistance to medicine is less problematic when you have pills like this because they're what are called fixed-dose combinations. And a fixed-dose combination means that if you have all three drugs in one pill, it means that you can't just take one drug. Because if you happen to take one drug, which happens all the time now in private sector treatment of HIV in places in Africa where somebody will be able to afford maybe 2 of the 3 drugs or whatever, if you can only afford one of those drugs, then you're almost asking for resistance because the other 2 drugs that you're taking will prevent the resistance. That is, if you have a resistant strain, the other 2 drugs will kill off that strain. But when you're taking a fixed dose combination, it means that's much less likely because you're always having the 3 drugs. So it's very effective. Finally, the prevention and treatment are what we would call a virtuous cycle. That is, one supports the other. Prevention, it controls the epidemic, reduces the number of people in need of treatment, allows for better use of resources. Whereas treatment reduces denial, stigma, discrimination, provides incentives to learn your status of HIV, which is a very important preventive tool. It preserves community structures, keeps families intact, reduces the size of at-risk populations. Supports people living with AIDS who can educate other people, and it lowers the transmission risk by itself because more people have their viral loads dropped, and therefore if your viral load is dropped, you're less likely to transmit it. So they both work together, and most people feel that, in fact, as opposed to undermining prevention, treatment has made prevention much easier in many places. But we've got a big problem. And the big problem is that African health systems still remain inadequate. All these other problems we've been able to deal with pretty well. But the one issue that's been very, very hard to deal with is the health systems. And the 2 big reasons are debt and structural adjustment. And here's where we go from medical science to economic to political science. Nearly all African countries have an unsustainable debt. Most of the debt is caused by global policies. And those global policies are aggressive loans that occurred during the period of time when OPEC was formed and there was a lot of oil money around in the 70s and the 80s. And those aggressive loans continued to the extent that a lot of the banks, number one, they made a lot of money in these loans and they had money to give away at that point. Second, changing interest rates. The interest rates in the 70s were about 5 to 7% when a lot of these loans were taken out, but because of policies that existed during the Reagan administration and in subsequent administrations, that the interest rates went way up, which they will begin to do here too, because whenever you have deficit spending, interest rates begin to go up, and they went up from 7% to 22%. And what that means is when you're paying off a loan, it becomes increasingly hard to do so, particularly when there are global subsidies in agriculture so that the value of your goods is less, the amount of the money that you're paying back is more, and it's a double whammy, which is why all countries in Africa have debt problems. It's not a problem of one country that would have bad management or another country that was in a particular problem. This is my version of the way debt repayments work. We'll talk about President Bush's $15 billion program for AIDS relief. Well, it turns out that if you look at debt repayments that are currently, that even after 10 years of debt reduction schemes, that the debt repayments right now are approximately $15 billion per year to U.S. banks and European banks from African governments. And this is government money. This means this is money that could go to maintain health facilities, to pay health workers, to buy cars, and to buy drugs. And then there's a second piece of this Washington consensus, pushed by the International Monetary Fund, the IMF, and the World Bank. And these are structural adjustment programs. And everybody in the United States who has any inkling of understanding the developing world needs to know what structural adjustment programs are. They're basically programs that are related to the debt to reschedule the debt to allow repayment, because there's no such thing as bankruptcy in countries. Conditional on reducing government expenditures, particularly on education and health, with the idea, particularly with the idea that came about during the Reagan administration, which we're seeing again today, which is all about governments being too big, governments being bloated, governments being inefficient. And the idea was to reduce their expenditures, particularly in education and health, to improve terms for foreign investment, so you can get this economic engine going, reducing corporate taxes by creating investment or tax-free zones, and continuing paying the debt. Oftentimes it's more than the health budgets. These conditions of structural adjustment have weakened national systems in Africa in a number of ways. That the budgets have been inadequate to support the procurement and distribution of medicines and supplies, the maintenance and the equipment of the health facilities, and this is a picture of one of the health facilities, which is actually in pretty good shape, but you can see that you're using bare wood, which, within a very short period of time is going to be eaten up by bugs. We're not talking about high-tech stuff, and because they can't afford it. They can't afford paint. You can't afford transport, communication. And then finally, probably the biggest issue is the workforce, the numbers, salaries, and the morale. And the reason why is because the International Monetary Fund in most countries in Africa has placed a cap on the total number of people that can be employed in the health sector and the education sector, because they're the biggest employers. Because that's the way to keep the overall budgets down for the governments. And what that means is that there are fewer people who can be employed, which means there are fewer people who get trained. And then you have two other things going on. You have brain drains. One is the external brain drain, which is a brain drain of nurses and doctors to the United States, to England, to other countries in the world, because they get so much higher salaries, and internally for better paying jobs within countries, which could be part of full-time jobs. And the reason why is because of these structural adjustment caps and salaries, what happens is that the real salaries of health workers have dropped in most parts of the world. So that a nurse who might have been earning, say, $150 to $200 20 years ago is earning $35 to $50, and sometimes less. Very, very common. This is not just one or two countries. So you have this situation where people are professionals who are working to feed their families, and they don't have enough money to feed their families, so they have to either do something else in addition to their salaries to make ends meet. Sometimes that's taking medicines and selling them on their own. Sometimes that's doing their work on their own on the outside, but to a large extent, it's taking a job outside of the health sector. This gives you an idea of the nurse-doctor distribution, that there are 16 million nurses in the world and 2.2 million nurses in the U.S. You can see what the numbers are. The nurse per population, per 100,000 population, is up near 1,000 per 100,000, and doctors are in the near 300 range. You can see that UK is substantially less, but look at India and look at Ghana, particularly the doctors' numbers. Just practically none. But Ghana has something in the neighborhood of 25% of all their doctors are in the United States or the UK. And in Ethiopia, there are more Ethiopian doctors in the United States than there are in Ethiopia. This gives you an idea of the nurse migration, because one of our faculty members has done a fair amount of work on this recently, and has pointed out the fact that nurse migration is in fact much worse than doctor migration. And if you look here, is that in South Africa, for instance, these are fairly recent phenomenon. As long ago as 98, 99, they were sending, say, 500, 600 nurses who were registered in the United Kingdom from South Africa. That's gone up to 7,000. Zimbabwe, 52 to 473. Nigeria, 179 to 432. Zambia, 15 to 183. Malawi. This is just to one country. Then you're talking to the United States. The numbers of nurses who, are major resources for these resource-poor countries that are going to the rich countries is astronomical. And it's an incredibly important issue in terms of how well countries can address the AIDS epidemic. So the summary so far is that, number one, AIDS is a devastating problem. Treatment works, it saves lives and fosters prevention. The prices and the complexity of treatment are reasonable, but the weak health systems are the biggest obstacle, and that the Washington Consensus is a big part of the problem. Now, we don't just have the Washington Consensus, because it's not as simple as that, because that way we could just change things in the Washington Consensus, we could deal with the debt and structural adjustment, but we have another issue, and that's the way we work as donors, the way the United States works as donors. And it's not what you think when you're out there. Now, here are some of the initiatives. There are a number of big initiatives. The 2001 UN Global Fund for AIDS, Tuberculosis, and Malaria, they've had 5 rounds of proposals. Something in the neighborhood of $6 billion has been committed. This is actually a fairly good system, and we're not going to talk a lot about that because the way that the money goes in the Global Fund is quite varied, and it's hard to pin down. The WHO, those of you who saw Jim Kim here a couple months ago, he talked about the WHO's 3x5 initiative, which is an initiative to get 3 million people in the world in treatment by the end of 2005. That's this year. And he thinks that's possible, and I think we'll get fairly close. Whoops. The 2002 Clinton Foundation initiative was to take 6 countries and try to develop national AIDS treatment programs that were universal and free in those 6 countries. And I'll talk to you a little bit about those, but there's not much money associated with it. But the one that we hear most about today is the Bush administration's so-called PEPFAR program that he announced in the State of Union address in 2003, January. The PEPFAR is the President's Emergency Fund for AIDS Relief. In the U.S. government, these are just some promotional things, that the U.S. government is the world's leader in responding to the global pandemic of AIDS, probably in terms of total money, if you assume that that money is getting to the right place. Second is that USAID has funded over $3.2 billion in nearly 100 countries since '86, and that's when PEPFAR started. And PEPFAR will contribute an additional $15 billion in 15 countries from 2003 to 2008. Okay, so that's pretty big funding. And in fact, I think that we have to say that that funding is probably the most generous, if this is straight dollars, the most generous health initiative that the United States has ever embarked on in the history of our global aid. However, the PEPFAR initiative has certain policies that are troublesome. And what I want to suggest, a couple of things about these policies. One is that PEPFAR says that we can only purchase branded drugs. Now, the branded drug companies, the big drug companies that were making these drugs for $10,000 to $15,000 per person per year, when all of this new AIDS treatment stuff came out, it became clear to them that they couldn't sit on those prices. Now, they are sitting on them here in this country still, and so that it's still quite expensive, but they have a price structure, as we know, that's different in Canada and other places in the world, and so they've developed price structures to lower their drugs to $600 per person per year. Okay, so that's the price that you can pay. And what the U.S. government is saying is that they're concerned, speaking of the double standard, they're concerned about a double standard regarding safety and efficacy of these generic drugs. And therefore, the PEPFAR initiative will not allow any money from the United States to be used to purchase drugs, except for these branded drugs that cost 4.5 times the cost of the drugs that you can buy in the Indian or South African generic companies. Also, interestingly enough, that because the branded drugs all are operating on patents, that none of these companies have patents for 3 drugs. Therefore, you can't put a 3-drug combination together. So as of today, there is no 3-drug fixed combination available. Now, there may be one companies are trying to get together because obviously they don't want to be criticized in this. But again, this is the push that happens. There's an idea of centers of excellence. They want to fund the best possible AIDS treatment. Again, sounds like, addressing global inequalities. But the idea is that they don't want to fund governments, they want to fund non-government organizations to do the treatment. There are 4 non-governmental organizations, NGOs, that are recipients for HART, and HART is AIDS drug cocktails, 3-drug treatment. It stands for highly active antiretroviral treatment. Each one of those recipients gets $100 to $350 million, and they're active in between 10 and 15 countries each. NGOs know how to spend money fast, faster than a lot of governments spend. And one of the ideas is that this is the best way to be able to develop AIDS treatment fast. And then finally, they've said that there should be an independent procurement of drugs, and about 6 months ago or 5 months ago, the U.S. government came out with an open bidding for a tender for contracts to procure drugs and supplies, but mostly drugs, for the PEPFAR initiative for $7 billion. Now, presumably that's 7 out of that 15, okay, although it's not really clear what the financing is. And the 2 major competitors for that were thought to be Northrop Grumman or Boeing. Okay, because they know how to do major distribution systems. And the idea was you can't trust the governments to do this distribution. It's going to go to the NGOs, so let's go through some mechanism. I'm surprised it's not Halliburton or, some of the others there. and then you look at the foreign assistance policies of the United States, and you realize that, well, maybe what we're doing isn't so far off of our policies. So if you go to the USAID website, and I picked this out several years ago, and the names change, but the concepts don't, because these have been consistent concepts for a number of years. But there are 4 basic objectives of USAID. Sometimes there are 5 or 6, but they fit this pattern. One is to expand U.S. markets. That tends to be the first. Because remember that the people in USAID have to sell USAID to Congress. And Congress includes a lot of congressional representatives from Iowa and from a lot of other places. So one of the big reasons for aid is to expand U.S. markets for grain, for cars, for whatever. Second, and drugs, of course. Second is to promote U.S. security. Third is to promote U.S. values. And the fourth is humanitarian. And usually humanitarian is somewhere sort of in the 3rd or 4th rank. Now, if you look at the policies in action, what you get is something like this. Expanding U.S. markets means, of course, you would support branded drugs because you want to establish a market for those drugs. Of course, you want to have lab tests that are made by American companies. You want to have cars, so you have to get special permission when you're working in most countries to buy Toyotas, even if they're better cars, because they want you to buy Fords. Promoting U.S. security means, for the most part, working in favored countries. Promoting U.S. values usually means privatization, as opposed to supporting governments, reducing public spending, et cetera, and then humanitarian are the program objectives that you tend to see. And then there's the issue of the way USAID money flows, or U.S. aid money flows. And this is not just AID, it's the CDC and a lot of other organizations. This is typically U.S. The Europeans will oftentimes take money and they'll put it into governments. But sometimes they put it into NGOs. And the way it works is that you have funding with this big, wide green arrow, and the arrows I've drawn in such a way that approximately replicate the amount of money that comes through. So a big wide arrow goes to non-governmental organizations because there's no huge infrastructure for direct U.S. aid mission to government funding. So they go to these non-governmental organizations, and then the non-governmental organizations like CARE, like Save the Children, like Pathfinder, like World Vision, get this money. And then some of it goes to direct delivery of services. A little bit will go to the Ministry of Health, but most of it goes to either indirect costs, which is overhead, and indirect costs are generally speaking between about as low as 20% and as high as 100 to 106% in some organizations like Management Sciences for Health or John Snow, which means basically half of all that money that they're getting is going to fund their operations in their environments. Now, you might think that this is crazy, but remember the University of Washington has an indirect cost rate of what, 51%? Right, 51%. So it's not unusual to have high indirect cost rates because we're expensive. It costs a lot of money to keep Kane Hall going. It costs a lot of money to keep the offices of these agencies going. So it's not to say this is bad, it's just that's where the money goes, okay? It also goes to high staff salaries. Now, these high staff salaries aren't as high as they are in the United States, but they're very, very high compared to the staff salaries in the countries where they're contributing. An example is the Columbia project that we're working with, and they have a PEPFAR grant in Mozambique. They have a total package for 2 of their staff members for $170,000 per year. Well, that's that includes housing, that includes a lot of other aspects of care, sort of a post-adjustment, et cetera. And, it's probably less than the equivalent doctor might make in the United States because it's very high, but imagine that when you're a Mozambican health worker or the Minister of Health who might earn, maybe $10,000 a year or $15,000. Or a doctor whose salary tends to be in the $100 to $200 a month, so we're talking much less than $5,000 a year. And then staff support, because you don't want these high staff, these highly paid staff to not be able to work well, so you got to have good cars, you have nice houses, nice offices, etc. So then you have the money going here, and then here's the money that goes to direct service delivery, and then a little bit to the Ministry of Health. Now, there used to be a rule at USAID where they encouraged recipients, the NGO recipients of aid, to try to get at least 25% of the total value of your money in country. And my guess, in the calculations that I've done, is that if we get 25% into this range, we're doing pretty well. I suspect it's about 20 to 25%. Okay? Now, that doesn't include that $7 billion for procurement and distribution of these drugs, which are priced at 4.5 times the price that you could get if these countries bought them themselves. So ultimately, and I figure on that one that we're talking between 5 and 10% of value. So if you average the 20 to 25% and the 5 to 10% of value, you're probably in the neighborhood of 10 to 15% of total value. Not very good. And then you have this other problem. And my son helped me with these arrows, which I thought they were cute. That you have this issue of donor funding, and we have the same process here. So you have donor funding going to non-governmental organizations and in-country organizations. And you have the salary issue that we talked about. These organizations have high salaries, benefits, good working conditions, air conditioning, nice computers, et cetera. And then you have the people at the ministry who are the people who are doing the work, who are working in offices with maybe a fan if they're lucky, with computers that may or may not be working or that are pretty old, and with fairly low salaries. And these are folks who trained at the University of Washington, people who, in fact, have very, very high levels of expertise, know what they're doing, but they've chosen to work for the ministry. Well, after a while, you kind of get to this point where maybe I don't want to keep doing that for my family and whatever. So what happens is that you have this massive flow of doctors, nurses, et cetera, to work for these non-governmental organizations, sometimes the donors themselves. And then you have less of a flow going to some of these local in-country organizations that also are organizations that will, generally speaking, pay more, even if they're much lower quality organizations. And then finally, you have this management burden. So an example is in the Mozambique Ministry of Health, you have over 200 non-governmental organizations, over 150 independent sites of operation, 10 to 20 program categories, independent planning cycles, implementation, and the reliability of these donors, that is the reliability of them being there next year, is dependent on the politics of Oslo or the politics of Berlin or the politics of Washington. So you can't count on them. So it's a management burden of tremendous consequence in a situation where you don't have a lot of managers. So the rich country obstacles, that is the obstacles that the rich countries bring in, are the following: the debt and the structural adjustment programs reduce public health spending in the first place, and they undermine care. Then the donors create parallel systems with the NGOs. Most of the donor money ends up back into the donor countries, and the estimates that we have for PEPFAR are about 80% or 90%. Donors are a management nightmare, and they contribute to the brain drain. So you kind of wonder, well, does it make the difference? Well, what are the solutions? And what I want to spend the rest of our time with is that there are some solutions and that they do work. One is to do what's called the sector-wide approach, which is having countries develop joint plans, unified procurement, and donor contributions to a single funding basket. That's what's done in Mozambique now. They've worked over the last 10 years to get this going, and the one country that doesn't contribute to that is the United States. You can develop a national plan, and that's what Mozambique has done. And they agreed to a policy of universal AIDS treatment in 2002 with the support of Bill Clinton. The Ministry of Health agreed to do a viable business plan, and the Clinton Foundation said, if you had a business plan that is viable, that the funders will fund you to whatever you need. It was an amazing thing to have no sort of budgetary limitations, and in fact, it did work. A little background on Mozambique: it's a very poor country of about 19 million, per capita income of $220. Annual per capita health expenditure is about $9 per person, although with debt reduction it went from 4 to 9, so debt reduction does help. The government spending on health care is about 11%. Literacy rates, as you can see, are relatively low, particularly for women. Infant mortality is about 101, and the life expectancy is 41 years, largely because of AIDS. The public sector capacity is such that there's been a health system since '76. There are about 600 doctors in this country for 20 million or 19 million. Over 1,000 health facilities, a well-functioning drug procurement and distribution system. Actually, it's quite good, even though the U.S. government wants to establish a parallel one. And about 140 doctors are trained in giving AIDS treatment. Their achievements have been legion. They've been able to get high DP3 immunizations, prenatal care attendance has been high, tuberculosis. They've had 28,000 new people every year in tuberculosis, and well over 70% have been completed treatment, and their health outcomes have been relatively good for a place like Mozambique. But you have a horrible AIDS problem. 6% in the north, 17% in the south, 13% in the middle, but with cities in the neighborhood of 25 to 30% of prevalence. The AIDS programs in Mozambique right now are primarily preventive, or were. They used to be almost completely. So here's the sort of pie chart of all the preventive care with information, and treatment is this little piece of 2%. The strategy for the AIDS treatment was to do several things. Upgrade and integrate HIV into the entire healthcare system, having a national procurement of inexpensive drugs and lab tests, simple HIV care and treatment, and avoid drawing resources from other government health programs. The idea was if you had new doctors, the new doctors would come in and they wouldn't do AIDS work, they would do other work, and the Mozambican doctors would be able to do AIDS work. The approach was to have an integrated network, which included a lot of aspects of HIV care, and I'm not going to go into a lot of detail here. This shows the integrated network, where you have voluntary counseling and testing and prenatal care with maternities going into an HIV care center, so that these places funnel HIV positives into a care center. The care center is able to identify which need treatment, which don't need treatment, and then be able to follow up the treatment. And the main thing is to have links with tuberculosis programs, inpatient, et cetera. The networks have been expanded to 24 from essentially 0 sites in 2002 to 24 sites by the end of this year. All of them are functioning right now. And what the government did was that they organized the donors, and it was very, very effective. They organized the donors to support the national plan with sustained funding, to contribute to the common pool with sustainable non-earmarked funds. That is, the money, there was a plan, but the money went in and it didn't have to follow any earmarking, which was critical because it meant that the Mozambicans could make decisions about how and when according to what the needs were, and supporting unified systems of procurement, treatment, monitoring, and evaluation. And here's what we have in Mozambique so far is that we started out with less than 500 people on drugs from the public sector. It's gone up extremely fast. We're right now in May of 2005. Our target was 16,000, and we're right about 12,000. So 12,000 people are in treatment. That's a 24-fold increase in numbers of people on care in a period of less than a year. So it can be done. There are constraints. We still have constraints of the ability that the Mozambique government has constraints of the availability of health workers. Doctors, nurses, lab techs, pharmacists still are in short supply. Continuing weak systems of care, so monitoring is tough, management's hard. There's a very a shallow managerial system and a crumbling infrastructure. They're addressing the constraints by hiring expatriate doctors to relieve Mozambican doctors, as I said, expanding basic training courses to increase their staff, to increase staff salaries. There's this thing called lunch allowances because the International Monetary Fund won't let us increase staff salaries. So what we're doing, or what the ministry is doing, is that you're getting a 30% lunch. Not a bad deal. Strengthening the management logistics and expanding the maintenance so that we're buying paint. The ministry is buying paint. They're doing a lot of work in maintenance. And addressing some of the NGO issues. Therefore, when an NGO comes in, the focus is to control the NGOs so that they're strengthening replicable public services. So that the NGO isn't just doing their own treatment, because that's what typically occurs. They're providing technical assistance within the government, in those offices without air conditioning, in the places side by side with Mozambique workers. And they've adopted the 3 ones of the World Health Organization and UNAIDS, which are having a single plan, a single procurement and distribution system, and a single monitoring and evaluation system. Public sector can make treatment work. It's very encouraging. It can maximize coverage and access to care, because these little centers of excellence, the NGOs, they're going to do something here, something here, something there, but you're never going to get the kind of coverage that you would otherwise get. These are some people in Haiti. Gives you an idea. This is Paul Farmer's group. It shows you what a young boy looked like in December 2002 compared to March of 2003 after being put on antiretroviral drugs. This is a woman in Haiti, again, with her child, October 2002 and January 2003. It's incredible to see how people respond to these drugs. Both of these people would be dead right now, for sure, if it weren't for the treatment. Progress is encouraging. Simple systems work. Adherence is very promising. Adherence is 95% in most places in Africa. Costs are decreasing. Treatment synergizes prevention, and universal treatment appears viable. The political commitment's growing, we think, because of all these approaches. And debt relief and structural adjustment are finally on the agenda. People are talking about it. You hear people talking about it, but the struggle is just starting. AIDS treatment is, in fact, an opportunity. It's an opportunity because AIDS treatment is feasible, mandatory in the light of a devastating epidemic that the world is finally beginning to see, that it's clear that a global effort is necessary to improve the basic infrastructure required to address it, and improving the infrastructure will force the global community to, in fact, reverse the structural adjustment policies that are affecting lots of other aspects of daily life. So, in fact, AIDS and AIDS treatment are an unprecedented opportunity we have to redress some of the market fundamentalism of the last 20 years. What can African governments do? You can develop a comprehensive plan, encourage donors to finance the national plans, including recurrent costs, that is salaries, use NGOs at the discretion of the Ministries of Health, and just say no when donors don't cooperate. And I was so pleased. Yesterday, in yesterday's news in the BBC, there was an article about the Brazilian AIDS program. The head of the Brazilian AIDS program told the United States government that we don't want your $20 million AIDS program. They said no. And the reason why is because the U.S. government said that the Brazilian government had to make a statement that was anti-prostitution. And the Brazilian government said no. And it was just so encouraging. It made my heart warm, because the same guy was in Mozambique about 6 months ago, and he heard the Mozambique government just say no to the CDC when the CDC told the Mozambican government that they needed to use the PEPFAR money to buy expensive drugs, and the Mozambican said no. So you can say no, and it works. What can Americans do? Well, we can cancel debt, we can reverse structural adjustment programs, strengthen governments, and advocate for living wages. We can help finance public treatment and prevention programs, including the purchase of generic drugs and recurrent costs, and we can provide money directly to governments or to the common fund, which goes directly to governments. That's 100% as opposed to 10 to 20% of the value of the money. And then on a personal note, just about a week ago, we had a visit of a woman named Florencia. She's somebody we've worked with, and those of you who have heard me talk about this before, a couple of years ago I gave a talk and I talked about Florencia, who was somebody who had just embarked on AIDS treatment. She's HIV positive. She's a mother of 4 children, 14 to 21, a nurse midwife, and she's the head of all of our maternal child health programs in a region of 2.5 million people. She's incredible. In 2001, she learned that she was HIV positive after her husband died of AIDS, her ex-husband died of AIDS, and she needed treatment right then. She's now been almost 4 years on treatment, feels great, works full-time, is sending her kids to college, and that's one of the things she was doing here in Seattle, is that she was trying to buy computers for her kids who are going to college in South Africa. It's an incredible success story, and this is somebody who wouldn't be here if it weren't for AIDS treatment. What we're talking about in terms of AIDS treatment is an incredible opportunity. AIDS treatment makes a difference, and it makes an enormous difference for people like Florencia and a lot of Florencias around the world. And what we do from the standpoint of our political policies, what we do in terms of our aid policies, make a huge, huge difference and can start addressing that treatment gap like we've never done before. The way we handle that, the way we manage it, is going to be, I think, a measure of what our society is for the generations to come. Thank you very much. I think we have some time for questions.
Steve, I would like to know what's the likelihood of false positive tests with regard to the sample testing that you discussed? And if that's a problem, that's an issue, what is something being done about it?
Thank you. It's my wife asking me this question. The likelihood of a false positive test is less than 1%. Now that's 1% is pretty significant. However, one of the things, obviously nobody wants to be have a false positive, nor do you want to have false negative. I think a false negative might be even more of a problem. If you have a false positive, one of the things that's going to happen is that you're going to have a CD4 count done right away. So if you don't have HIV, then your CD4 count should naturally be fairly high. You're certainly not going to go on HIV treatment with a false positive HIV test. So a false positive HIV test, even at that 1% level, is going to have social implications that are very serious, just like any other positive test would be, but it wouldn't push you into treatment.
Given the problems you have described with U.S. policies, can the African countries address their AIDS problem without U.S. support?
Yes. All you got to do is look at that graph of the $15 billion that goes up every year for debt repayment. It would be so simple. Eliminate the debt and the money exists, and that's 100% on your dollar as opposed to 10% on your dollar. So of course they can. If African governments had that money and they needed technical assistance, they could hire technical assistance on their own basis, on their own terms. And that's what Mozambique is doing when they get money in their common basket from the other donors. So I'm convinced that you don't need U.S. assistance. Now, I would never recommend that because I think as human beings, as Americans, I think we're a generous people, and I think that we should contribute because this is not just Africa's problem, this is all of our problem. Therefore, I think we should contribute, but I think we should contribute in two ways. We should do for the poorest 50 countries in the world what we did for Iraq, which is to cancel the debt. Iraq's debt was $103 billion or $7 billion, something in that neighborhood, that the Bush administration just pushed. That was one of the first times that the rest of the West came around and said, well, gee, if we're doing this for Iraq, why can't we do it for the rest of the 40 poorest countries in the world whose total debt is less than $50 billion? But no, the U.S. fought against it, and the U.S. is still fighting against it. So I think that the best thing we can do is to eliminate the debt, and then the second best thing we can do is we can contribute to either governments individually, because I think it's okay to say, okay, we're going to give more money to Mozambique than Zimbabwe because we don't like Robert Mugabe or something like that. But I also think it's a good idea to give to the Global Fund, because the Global Fund is an international mechanism that distributes money to the entities that need it without having all this siphoning off that occurs. So there are very real ways to do it. So I think we should give. I don't think we have to. I don't think it's necessary, but I think we should because it's going to make things better, because these things do cost money, but that there are better mechanisms to do it. Okay, well. Thank Dr. Gloyd again. Okay, thank you.